Ayo is easy, and to sign up is just as easy. Meet Abel Mutula from the barbershop in Kalingalinga. Abel Mutula is also an Ayo customer.
My name is Abel Mutula. Signing up with Ayo was easy. This is how I signed up. Step 1, dial *296#. Step 2, select 1, sign up. Step 3, select either 1 for my hospital or 2 for my life. Step 4, fill in your age and confirm. Step 5, select 1 to accept the Ayo terms and conditions. Well done, you signed up. Now let's add my loved one.
Ayo together with MTN. Ayo, because you care.
Hello, good evening, and welcome to today's Ask Dr. Mjajati Sunday. And like I told you that today we are, like we announced earlier, today we are discussing our healthcare system. A lot of people who acquire services from our healthcare systems have complained about a number of issues. And we've also had headlines that have been very, very unwelcome, and headlines that have been very unfortunate relating to the healthcare system in Zambia. So today we are discussing the issue of how then do we build back the confidence in our healthcare system, particularly our public healthcare system, seeing that our public healthcare system is the largest provider of healthcare services. And to help me discuss this very, very important conversation, I have with me Dr. Moyo, and I have with me Dr. Mupeta. Later on, we'll be joined by Mr. Jerome Kanika, the former president of the Pharmaceutical Society of Zambia. He's running a bit late, but he will join us soon. While you're at it, please tell us where you're watching us from. We would like to know where you're watching us from. Now, help me make welcome my guests this evening. And without wasting much of your time, I would also like to thank Ayo and MTN for making this conversation possible. And as usual, at some point, we'll allow you to ask questions to the panel and be very interactive in your questions. Right now, I will ask Dr. Moyo to introduce himself. Dr. Moyo, go ahead and introduce yourself. And by the way, Dr. Moyo, congratulations on your election as president of the Zambia Medical Association. And I'm sure you have much to say about that. So, Dr. Moyo, please introduce yourself.
Thank you very much, Dr. Mjajati, for hosting me and the other panelists on this show. Dr. Crispin Moyo is my name. I'm a public health practitioner, and I've also got interest in the area of HIV, and most of my work has actually evolved around HIV and public health. Like you have already mentioned, I would like to thank you for coming me as the incoming ZMA president. To begin with, maybe I can also, for the sake of the viewers, mention that ZMA is an official representative of the medical practitioners in Zambia, committed to promoting and maintaining high standard of medical practice through the provision of continuous medical education to its members and influencing national policy and public opinion in the health matters in Zambia. So basically that's what we are all about, and hence our interest in participating in such kind of a forum where we'll be able to advocate on behalf of our patients and also promote good practice. Thank you very much.
Thank you, Dr. Moyo. And Dr. Mpeta, I believe, Dr. Mpeta, you are not alone. I have seen that we are joined by Dr. Wando as well. So, Dr. Mpeta, could you quickly introduce yourself? And then after that, Dr. Wando can also introduce himself. Then we can get into the subject. I know, Dr. Peter, you're not new to this platform. People have met you before, but in case there are people who are seeing you for the first time, please go ahead and introduce yourself.
Thank you very much, Dr. Mtijati, for having me on your show. My name is Francis Muketa. I'm an infectious disease specialist. I'm also a consultant physician at the University Teaching Hospital. Mostly, we deal with everything infectious. So the bulk of our work until recently has been HIV and TB. And then with the coming of the pandemic, basically, I have mostly been at the front lines and also at a technical level in driving, the management of COVID-19 cases, and also formulation of strategies on how to tackle COVID-19. Previously served as the Secretary General of the Zambia Medical Association, so where Dr. Moyo is, we had served earlier, in another capacity. So basically, that is it about myself.
Right. Can we also have Dr. Lwando introduce himself? I can see that Dr. Lwando is with you, and it would be nice to also get his input in the subject. Dr. Lwando, please introduce yourself to the people.
Good evening, Dr. Mtijati, and good evening, viewers and listeners. My name is Dr. Alex Lwando. Currently, I'm the head of Department of General Medicine and Rheumatology at Mainasoko Medical Center. I previously served in the Zambia Medical Association as Chair of Medical Education and Research. I have very strong interest in the healthcare system strengthening, healthcare financing, and the healthcare management. So basically, in a nutshell, that's me. Thank you.
You're welcome, Dr. Lwando. So, gentlemen and viewers, we are expecting to be joined by Mr. Jerome Kanyika. Jerome Kanyika used to be president of the Pharmaceutical Society of Zambia. We feel that he has something to say on this platform. Now, to get us rolling, gentlemen, in my introductory remarks, I talked about the fact that there's low public confidence in the healthcare system. Now, in talking about healthcare systems in Zambia, gentlemen, you'll agree with me that we'll be talking about both public and private. Now, can we sort of put things in context? Dr. Moyo, kindly walk us through when we say a healthcare system for Zambia, what exactly are we talking about?
Yeah, so thank you, Dr. Mtijati, again for that opening statement. And I want to begin by saying that the health service provision in Zambia is currently not premised on any piece of legislation since the repeal of the National Health Service Act of 1995, which led to the Central Board of Health. So at the moment, we are sitting on the law that allows the Minister of Health to function as a provider of health services. But the Health Services Act, which brought into play the Central Board of Health, was repealed. I think it was in 2006. And since that law was repealed, we have not had a forerunner to that law that defines the provision of health. Not to say that there's a lacuna in the provision of health services. The Minister of Health, through the necessary statutes, has the mandate to continue providing the services. And in these services, it's defined by the what is called the basic healthcare package. And in this basic healthcare package, it's defined by the levels of care that we are able to that we provide in our different facilities. So you have primary healthcare services, which are provided across all the health systems, and then we begin to increase in terms of sophistication as we go up the levels. So you go into the district health facility levels, which have got higher levels of services that can be provided, including maybe inpatient facilities with provision of theater services. And then you go up to specialist services, which can be offered at both general and central hospitals. Then you have the teaching hospitals, which are the super specialized. But in general, the health is organized into two main building blocks. We have the public sector and the private sector. Both very important to ensure that there is a equity of access to health services for most of our population. So in the public sector is basically divided also into two. We have got the government, which is under the government of the Republic of Zambia, providing all the services from tertiary level to primary healthcare level, including community health services. But we also have other partners like non-government organizations and the church organizations, which provide services across the board as well. But this is under the umbrella of the non-governmental organizations providing services. At the moment, I think that's how I'll describe our health system. Does this health system? Yeah. Thank you. Thank you,
Dr. Moyo, for that description. Mr. Kanyika, quickly introduce yourself. You haven't missed much. We have just finished introducing ourselves, and welcome to this conversation. And Dr. Moyo has just finished describing the healthcare system. So just quickly introduce yourself, and then we move on.
Okay, thank you, Doc. Good evening, Dr. Mpeta, and good evening, Dr. Moyo. It's nice to see you. My name is Jeremy Kanika, the former Pharmaceutical Society president, and I'm a pharmacist by profession.
Welcome. Now, Dr. Mpeta, quickly tell us, there's a sense that the confidence in our healthcare system, particularly the public service system, and we are going to focus our conversation around the public service because that's the biggest provider of healthcare services in Zambia. So now, there are sentiments that the public confidence is at its lowest. Why do you think public confidence is low? Dr. Mpeta.
Yeah, thank you very much, Dr. Mjajati. And you have rightly said so. Over 92% of service providers, is public. One has to look at exactly what has happened, over the past few years with regards to the health sector. So we remember that the health sector initially was rocked, on scandals. A decade ago, it was, the infamous, supply of certain, products to the Ministry of Health, a case that was, prosecuted successfully in court and conviction secured. Then just after we recovered that, in the past 5 years, we had the issue of exaggerated cost of ambulances. Then we had the issue of drugs, supplying of, the honeybee saga, where, expired drugs with colossal millions of dollars, we are supplied to Zambia. Then as we were trying to recover from that, we were hit by the pandemic. And then the pandemic itself also had its own scandals. Most of the things have been highlighted in the Auditor General, where resources were not applied as they were supposed to. And something that is very fresh is, the vaccines, the unauthorized vaccines, about 10,000 doses that came through the private means. And then these were not supposed to be on the Zambian market, which led to Zamra. Is it Zamsa now? Is it Zamra or Zamsa? Zamra destroying, those doses. So if we look at all this and the main scandals which, led to changing of ministers deep in the pandemic, and also, the permanent secretary appearing before, courts of law, that actually created a lot of anxiety. And I think it's what has been, what has led to where we are, where the public, confidence in the health system has gone down. And we have seen where if people are given a prescription, it's very difficult to find drugs in the facilities, and this also erodes the confidence of people and the services that they are getting. So all these scandals, plus what people have been observing, where certain services cannot be provided, has really, really, demoralized the public in trusting, our healthcare system.
Mr. Kanyika, what's your comment on that? From your perspective, why do you feel, or first of all, do you agree that public confidence in our public healthcare system is low? And if you agree, why do you think it's like that?
Yeah, I think there is a serious there's serious problem in terms of public confidence in the Ministry of Health, and for sure the public currently they have no confidence, and they are trying to see if they can build the confidence through having the new government in place. I think one thing that we need to know very well is currently the way the Ministry of Health is being managed in terms of the pharmaceutical sector is very, very sad, as we know very well that Zambia is the only country where we don't have a policy in the way the pharmaceutical sector need to be administered. The last policy which was there was in 1999 policy, which was signed, I think, by the former minister, by Professor Nkamdruo. She was the one who signed a national drug policy. Now from there, we have never reviewed, and things have just been like that. You see, in the midst of the confusion, there are people who are benefiting, and in this situation, people have been trying to benefit for all these scandals that we have been trying, that have been coming out for selfish gain. So what first need to be done is we need to put a proper drug policy in the country and have it a well thought of and put across. Currently, it is not here or there. Then the other challenge, one thing that I've seen, we are weak as a country in terms of Ministry of Health, in terms of formulating policy that is going to deter people from finding in wrong vices, or vices that may make the patients not have the medicine that's supposed to be done. There is an audit in terms of how the drugs are coming inside the healthcare system, but there is no audit on how the drugs are going to the patients, how many patients have been given. Provided the drug is being issued to dispensary, there is no any further audit. So in that situation, these are the challenges that we are having, and the challenges that has resulted in most of the drugs not being given to the patients accordingly, or not having a value for the same drugs that have been there. So these are some of the things that we need to develop, and things that we need to express well in the policy that's supposed to be there, especially for the pharmaceutical sector. It feels very bad. A doctor writes a prescription, then you in the pharmacy there, you just tell the patient to say, no, go buy this medication. How can you assure the patient that they are going to get the quality pharmaceutical care, the quality medicine? You are not assured, and the patient goes get something which are not well proved. You find that they come back 2 days, 3 days later with a lot of side effects which we are not expecting as a medical personnel. So it's very painful, actually. It's very, very painful for us, especially as the pharmacists who pass through, who are tormented on a daily basis by stockouts of drugs.
Right. Thank you very much. Dr. Moyo, would you like to add under 1 minute why you think public confidence is low in the health sector, particularly public sector? Under 1 minute, can you add to what the two gentlemen have said?
Yes, just in addition, I think all the points have been made, but just to add that I think we need to inculcate or bring in accountability and transparency in all the sectors that are related to health. I will just pick, since I only have 1 minute, I'll just pick on Zamra, for example. We know that there was an importation of the so-called vaccine, which subsequent was destroyed without any investigation whether that was actually a vaccine. But that's not really what worried me a lot. What worried me the most was that the importer is not even a pharmaceutical company. How do they know what they're importing? So from the outset, I think we need to put in place systems where we are accountable to our people. At the moment, it's not possible to ascertain that what was actually imported was even a vaccine. I don't know what was in there, because then you go ahead and destroy it. What proof do I have that what was being brought into the country was the vaccine? So these institutions need to inculcate, or they need to build accountability systems, so to speak. Thank you.
Right. I'm glad you and Mr. Kanyika sort of touched onto the next topic that I'd like us to look at. Let's look at our supply chain. What is the current state of our supply chain? Mr. Kanyika, you start this conversation. Tell us the current state of our supply chain. Because it appears, and also Dr. Mpeta touched on that as well, that, our supply chain, a lot of things have happened in there. There have been scandals of corruption and supplying of drugs or commodities that are not up to scratch, and that has lowered public confidence. Now, Mr. Kanyika, tell us, where are we? What is the current state of our supply chain for drugs and commodities?
Thanks, Doc. I think in the current situation is not anywhere good to say, if I can say so. Just like Dr. Mpeta mentioned about the issues of how fake drugs found themselves in our facilities and all that, and not that they were recalled. The fact which is there is those drugs were consumed by the members of the public. That should call now a serious one in terms of how ourselves we do in terms of supply chain. What things do we put in place? And also what Dr. Moyo has also mentioned, to say institution that's supposed to be put and it's supposed to do the correct thing, like institution like Zambia Medicine Regulatory Authority. Unfortunately, on a daily basis, they get threatened by the politicians, and for the bad part was in the previous regimen, the Zamra were right, left, center threatened in such a way that they were even made or called to sign a certificate on a Sunday, which the day they don't work. So this is now what you see in terms of how political intervention comes in, if it comes in a wrong way. So we hope with the new government that comes in, institutions that's supposed to be autonomous, they are going to be very much autonomous, and people are going to be given authority. Because for your own information, it is only in Zambia where you can find a fake medicine in a government institution with all the state machinery. Even in Afghanistan, where there are problems, you will not find the fake drug being administered to people. No, but only in Zambia, as if we are at all, but we have never been at all. But because of corrupt political appointees or politicians who wants to put the hand in terms of the supply chain, that has resulted us having that. Currently, just like I keep saying, to say in 2021 budget, we had about 1.4 billion that was budgeted for to buy drugs and other medical supplies. By May, we used about 953 million kwacha to buy the drugs. But when you check very well, from January to December, hospitals have no drugs. When you go right now, you find that for sure there are no drugs in the hospitals, especially on the essentials. This brings out a lot of problems. And when you check on the other hand, we have another thing that have come on board, which is NEMA. You see, that's supposed to help in terms of financing the health sector by also helping in procuring the drugs. But you find that they also don't have. Why? The system in terms of the pharmaceutical sector, it is still very corrupt, very, very corrupt. And to make the matter worse, even senior government officials have been entangled in this kind of system that have made it so very difficult in putting it very, very straight. Like Dr. Mpeta mentioned, in 2000 somewhere there was the issues of the Kapoko and all that. When you found this time that was there was some prosecution that happened and all that, and people were jailed. Then some people were made like they were acquitted, but again being brought back in the government system, there is already all scandals and the vaccines, ARVs, all those kind of things. There are people, they are still there. This now can say to you that we still have a hand which is so political and that is affecting all the good thing that's supposed to be done. The pharmaceutical sector is very, very bad currently.
Right. So, Mr. Kanyika here is from a pharmaceutical background. He's also the president, immediate past president for Pharmaceutical Society of Zambia. He is not happy with the current state of our supply chain in terms of drugs and commodities. Dr. Lwando and also Dr. Mpeta, you can comment under 2 minutes each. I'll start with you, Dr. Mpeta. How do you think, no, let me start with Dr. Lwando. Dr. Lwando, let me start with you, because you are an expert on healthcare management in terms of systems. In 2 minutes, what do you feel should be the critical issues that would need to be looked into in the drug supply chain for us to mitigate the issues that Mr. Kanyika has raised?
Okay, thank you very much, Dr. Mzazati. I think we must look at healthcare holistically so that we find the solutions to all the issues that we're facing. Because if we have a siloed approach, we'll just look at drug supply chain and we don't look at other issues, we might find ourselves in the same pitfall that we are in at the moment. So I think central to me is governance. Governance at the level of government, at the level of the Ministry of Health. When you look at the healthcare system, it encompasses three things. It's looking at the people, it's looking at the institutions, and then it's also looking at the resources that are supposed to be provided. Yeah. So now, the bone of contention has always been, right now in the healthcare system that we have, is that the regulation, the healthcare provision, and the training of personnel with the coming in of the Mwanawasa University is under the same umbrella. And that's one biggest misnomer that we have. In the previous regime, we saw that even in terms of the supply chain management, the procurement of resources was also under the same umbrella. We have a very serious conflict of interest. So the first thing that should be done is separation of all these sectors. In the recent past, we have seen the changes to the HPZ Act to give more power to the Ministry of Health over the HPZ. HPZ is the regulator. So we have the provider, who is the Ministry of Health, having so much control over the regulator, which is HPCZ. So how will the regulator now regulate the healthcare provision? Then we have a system where HPZ will not just be rubber stamping whatever the Ministry of Health is doing, which is wrong. We have the Mwanawasa University that is training healthcare providers being managed by the Ministry of Health, which is supposed to be the provider. So the first thing that we're supposed to do is look at the governance issue. How do we separate the regulation of health systems, healthcare, the provision of healthcare, as well as the training of personnel that are supposed to provide healthcare? And once we have those separate, everything is now going to fall in place. Thank you.
Thank you, Dr. Lwando. So, Dr. Lwando, based on the problems that you've identified the issue of governance as a core issue that needs to be taken care of. Now, Dr. Mpeta, in 2 minutes, what should we be looking at to try and fix the problems that Mr. Kanyika has brought out? He basically says our supply chain is in a mess currently. And Dr. Lwando's position is that we need to address issues of governance, basically in the way the system is structured. What is your take on the subject, Dr. Mpeta?
Yeah, thank you very much. And then on a lighter note, I think I would like to quote the Republican president, where he mentioned that immediately you'll be sworn in, the markets are going to respond. So similarly, if you have to, change a lot of things and shake up a system that has been in slumber, it's to work on perceptions. And right now, the current narrative is that the Ministry of Health is corrupt. So when it comes to having a new administration, to change that perception, there has to be some form of shakeup. So, we have to look at governance and leadership, which Dr. Lwando initially, alluded to. The moment this is strengthened, then you already have at least one step into confidence being built. Then the other aspect is to look at the supply chain system and who are the key players. All right, which of these key players are reputable? They have got a track history of being suppliers, and instead of this overnight companies which are being formed on a Sunday, and on a Monday they are already supplying drugs. I think it's something that we have to do away with. We look at the seasoned, key players in the pharmaceutical industry. Secondly, we have to strengthen institution of that safeguards what sort of things that we consume on the market. So we have to look at ZAMRA itself. We also have to look at the Zambia. The ZAMSA, what is it called now, Mr. Kanika, the previously medical stores. So both institutions need to be strengthened in that once the public supply chain system for pharmaceutical products and other commodities, then we find that the confidence definitely is going to come back. So we really need to start seeing new faces there, new competences. And also in the Ministry of Health procurement system, we also need to have it, shaken up so that when we have got, certain competences there, at least there will be that confidence which is being done. And, we start looking at how should the procurement processes be followed, because this became non-existent. And once we deal with that, then we'll start looking at, the tendering process for this. And then, we follow the law. It was very disheartening to note, the director of clinical care from Ministry of Health having notified the country that Zambia owes suppliers 2.2 billion. Now, that's so scary. How do you even go back to have, emergency supplies? How do you even begin to settle? So it is important that we look at the governance issue, in the first instance. And then in the second instance, we look at the processes itself, the procurement processes, and we've got enough laws in Zambia, and we just have to ensure that these are applied. And then those that still remains obstacles, we look at wherever we should address them and, have them, repealed or modified or changed. So that's what I think should be the case.
Thank you, Dr. Mpeta. Gentlemen, I know that the issue of the supply chain can actually be a topic on its own. It's a very long subject, but I'll quickly move, since we're discussing systems, I'll quickly move you to another component that we need to discuss here. We are going to talk about human resource for health. Human resource for health has been a big issue, and for us, it's quite paradoxical that you don't have enough healthcare workers serving at present moment. But at the same time, you have a lot of healthcare workers that are on the streets and they are unemployed. Now, that's a very, very interesting situation to find yourself in. Dr. Moyo, you are the president of the Zambia Medical Association. You represent a segment of healthcare workers. Mr. Kanika, you are a former president of Pharmaceutical Society of Zambia. Now, I'll start with you, Dr. Moyo. The issues that relate to human resource for health, and as it relates to the issues of the doctor-patient ratio, in terms of the ideals that we need to reach, we are way below the ideal, and yet we have healthcare workers on the streets. What's your reaction to that in terms of, where we are as a country in terms of human resource for health?
Thank you, Dr. Mjajati. May I just touch a little bit on the supply chain before I move into HR? You just say in under 1 minute. In under 1 minute.
Under 1 minute, yes. And then tackle the HR issue.
Yes. So if you look at our supply chain as well, Mr. Kanyika mentioned the issue of accountability ending at the point when the medicines are supplied. I think we need to put in place systems that are able to tell us what is happening where the commodities are being consumed. For me, that's the biggest missing link, because all we are doing is that we're sending billions of kwacha, dumping these billions of kwacha in terms of commodities in the facilities, and we don't know what happens to those commodities. For all I know is that anything can happen because of no systems to account for that. So we need to make sure that we build those systems. And if we can find a way of having stock visibility and consumption at facility level, which is either electronic or digital, that will help us, to begin to have more accountability across until the patient has received the commodity. Coming to HRH, or Human Resource for Health. Yes, it's a paradox that we are in, where we have ratios that are below the global standards, and yet we have healthcare workers that are roaming the streets. And just last week, we saw the PS admin writing to the about 700 or so healthcare workers who were brought in the midst of COVID under the World Bank project, being told to that their contracts have been terminated. Now, so we are between the rock and the hard place here. It's one thing to say that we have no resources, but when those resources are actually available, how do we ensure that the healthcare workers that we have recruited are equitably distributed to for us to be able to achieve universal health coverage? So we need to start thinking outside of the box. I mean, we need to open our mind. We need to think out of the what has been normal. We have the whole area of primary health care, which basically hinges also on how we can develop a private sector that can absorb the majority of our staff. Here, I would venture to even say that if we can strengthen health financing, which can increase access to primary healthcare services for anyone who is either in formal employment or they can access health services through Social Security, we would be able to allow the private sector to thrive and absorb clients, those clients that are on the schemes, to be able to benefit from the services that the private sector can offer. In so doing, all we are going to do is that we are going to have alternative beyond government in terms of employment for our healthcare workers. This will allow also our senior doctors, like ourselves, who are about to retire. We retire, we leave the health system so that we are able to absorb the young ones who are coming and they can take on over these positions. So we need to think how NEMA or how healthcare financing can spur activity in the private sector and absorb the bulk of patients, the bulk of clients who actually congest our health facilities simply because it's too difficult for them to access private health services. Yeah, and that will relieve the pressure on our health system. Thank you very much.
Dr. Mpeta, what's your take on this?
Thank you very much.
What's your take on that question?
Yeah, thank you very much. Yeah, indeed, we are in a paradoxical situation where, there's starvation amid this plenty. We've got a number of healthcare workers who are on the streets, though not enough to really meet the demands of the sector, but at least we still have enough trend that if they were absorbed, at least it will cushion, some of the effects of the shortage of HR. Now, one thing that we have to understand that the provision of, adequate HR in the health sector is strongly hinged with universal health coverage, meaning providing health services to people where they need them. And there is actually a World Health Assembly resolution to that, where it is a global agenda that we need to provide healthcare services that are affordable to as many of our populations as possible. Now, if you see this, to have a robust healthcare coverage, it has to be closely married with, healthcare financing. So you find that the three are well linked, and actually resolutions have been made which are well linked and speaking to each other. So I would like to concur with Dr. Moyo, where we say if we have to look at the human resource, it has to be seen in the light of universal health coverage. And then the two have to be hinged or supported by healthcare financing. And healthcare financing, we have to strengthen the structures that are in place. So there are two modalities at the moment that we are using. There's the direct pool funding from central government, and also we are raising contribution, based on a solidarity from those that are capable through the National Health, Insurance Management Authority. Now, if we have to really ensure that we support the human resource, like Dr. Moyo said, if we look today, 92% of services are provided by the public sector. Now, the public sector is the same one government told us a few, weeks ago that it's broke, the coffers are empty. So meaning employment cannot actually occur. So now, how do we ensure that these health providers who have been trained at a huge cost actually are capable of being absorbed into the sector? It's by expanding the base of employment. So instead of 92% of services being provided by the public sector, which is government, we have to, look at, outside sources, which is the private sector, where they increase their share capital from 8% to probably even 30%. Now, if we have a thriving private sector, then we have got all this, being employed either by the public sector in 70% of cases and the public sector, in 30 to 40%. Now, if the private sector have to thrive, then there has to be a system where the majority of the population are able to access services through the private means. Now, if we were to look at a proper healthcare financing system that could even suit in our environment, is were to look at the UK, where both private and public institutions are actually drawing the fund from the same pool. So these are some of the models that we have to look at. And once we do that, we'll find that the issue of HR is going to be really, really a thing of the past, and then we shall move towards universal health coverage.
Mr. Kanyika, my next topic, I think Dr. Moyo and Dr. Mpeta touched on my next question about healthcare financing. I'll come back to that. Mr. Kanyika, what's your take on this problem of human resource in the health sector? And under 2 minutes, how do you think we can fix this problem of healthcare, of human resource in the health sector?
Okay, thank you very much. I think if we have seen most of my former members, like I can say, so the pharmacies suffered a lot in terms of them not being employed. Well, we have we have about 57% of their structural position being frozen by the Ministry of Health. That's something very much unacceptable. Before I comment on this, let me first concur with what Dr. Mpeta said about Director of Clinical Care talking about 2.2 billion. The thing that we need to do, we need also to ask ourselves, from the 2.2 billion, how much of this money were for drugs that were fake? How much of this money were for drugs that were recalled? Because there is also a situation here in Zambia where drugs are recalled and no one replaces. And that's the way it is. So now you wonder and to find out to say, if I've been given a contract, I supply drugs, then the drugs are recalled to say they are fake or they are not okay. Then instead of me supplying new stocks, I end up just going away with the money just like that. Why this thing happen like this? Because there is some politicians who are involved and who influence the contracts for these companies. And we have also a problem with some companies who have been supplying us drugs for a longer period of time, manipulating the prices for these commodities so that they share the money with the politicians. So these are some of the challenges that we have been having. Coming back to the issue of manpower, I think it's very sad when we check in terms of the manpower for Ministry of Health, especially when it comes to to pharmacies. We are totally highly understaffed, and most of the people who work in the hospitals, they are made to work long hours and serving a lot of patients as compared to the
Mr. Kanyika, are you there?
hello, are you
Yeah, we
able
can hear
to
you.
get me?
Yeah, we can hear you.
Okay, sorry, are you able to get me now? Sorry.
Yes, we can hear you.
Let me mention to say to everyone who's calling me, I'm using the phone for this program. So when you see me on this program, please know that the phone is engaged on the program. So please bear me for this. Please, I'm asking, I'm begging. I'll go back.
Must be some members who are doing that.
People want to tell you that they have seen you, you on the page.
Not come on,
Yes,
yes.
I've seen you on the show. Yes, I'm there. I'm the one. I'm live. Yes. Yeah. So most of the thing, what you need to find, you'll find that we are having some of these challenges because we don't have quality, or we don't have numbers for healthy workers that's supposed to be or serving the members of the public. As a result, you find that where they are supposed to be a doctor, there's no doctor, and the patient is seen by Dr. Ochman. I call them Dr. Ochman, especially when you go in the facilities. What they are going to do to that patient, they are going to do more damage and more harm to the patient as compared to the problem the patient came with. So this eventually will increase on the burden and also on the cost that is needed to fight the disease the patient had at first.
I think Mr. Kanyika has received another phone call.
He's famous.
He's very famous.
Yeah.
Yeah, sorry. Yeah.
You received another phone call.
Members and their problems. I think that's the challenge which is there. Karen, can you get me? Are you getting me?
Yes.
Yes, we are getting you.
Yes.
Are you getting me?
Yes, we are.
Are you getting me?
Yes.
Okay, yeah. So currently, if I can tell you, I have about close to 1,000 pharmacists who are working in government institutions for free without any pay, but they're there to provide the service. This is the challenge that we currently have, and we need to put proper resource in the health sector. And NEMA was such a brilliant thing for help in terms of financing the health sector. But when you see NEMA is also going the parallel or opposite way, that's the challenge.
Now, Dr. Lwando, I think the closing remark from Mr. Kanyika has just drawn us into my next issue, the next subject matter, which is healthcare financing. Now, healthcare financing is quite broad, as you would agree with me, Dr. Lwando. Now, here I want us to narrow down this healthcare financing to one issue, which is this national health insurance scheme of ours. It's been implemented for slightly over 2 years now, if I'm not mistaken. How has it performed, Dr. Lwando? And in terms of contributing to healthcare financing, is it really contributing, or we need to give it more time?
Thank you very much, Dr. Mzarati. I think the discussion of NEMA is a very big discussion. And looking at the foundation, what the founding concept, why NEMA was formed, and the parameters or the objectives that it was supposed to achieve, NEMA is a solidarity scheme. It's a solidarity scheme in that it's an insurance company, in inverted commas, that is run by government. And it was formed to answer a few questions. First of all, it was supposed to question the healthcare financing in the country by being a third payer away from the government coffers. Secondly, it was formed to bring about the solidarity concept, where the rich will subsidize the poor, the healthy will subsidize the sick, and the young will subsidize the old. So it's a social security concept. And then thirdly, it was brought in to sort out the issue that we are discussing now of employment by forming a much wider base of employment By this, I mean physicians were supposed to employ fellow physicians to set up their practices, attend to the Zambians who are the patients, the citizens, and then NEMA will reimburse this. And this will be used as salaries, it will be used as a reinvestment into the clinics that are supposed to be opened. And this was also supposed to boost the healthcare provision even to the rural areas. Because if there's money lying around, we're talking in the previous topic, we're talking about human resource for health. While we have healthcare workers that are roaming the streets, and yet we need these healthcare workers. If we have the concept of NEMA funding the group physicians, these can be set up even in the rural areas. And this will sort out the issue of urbanization or centralizing the healthcare systems in the services in the urban areas. Coming to your question, has it performed according to expectations? I think you have to, sorry about that. I think you have to give the current NEMA management a pat on the back because they have navigated the first. I don't know if my colleague, Dr. Mpeta, will agree with me, but they have navigated the initial obstacle that they had. You know, they operated in a harsh environment. They operated under iron fist, but they have set up the foundations of how this government healthcare insurance scheme is supposed to run. They have been operational in less than 2 years. In October, they'll be clocking 2 years. The contributions that are getting from the informal sector are almost, I think, 95% or so. The issue now that they have to tackle is the informal sector. And, you know, the informal sector is a bit difficult to tap into, especially that we've had the pandemic, but they're making strides into tapping into the informal sector. So they are still expanding their contribution base. So what we are supposed to be thinking about now as the healthcare providers is how we can tap into NEMA as a third payer. Right now, they are going into supporting investments. If you want to open up a clinic, you bring in equipment, they are able to pay for that, and then over time you repay by attending to their members. So if you are to ask me how NEMA has performed in less than 2 years, I would say that they have set up the foundation. It's now up to us to give our input so that now we move to the second stage. The second stage will include ourselves going into the rural areas, ourselves going into where healthcare is needed the most and provide it there. And then the payment reimbursement comes through NEMA. And that also, the second stage also includes how we are going to tap into the informal sector. Because at first there were a lot of hurdles, there are a lot of misconceptions, understandings of how this concept was going to work. And so far, we have seen that's a concept that can work. All what remains is now to see how we can strengthen it.
Dr. Mzatati, since I'm next to
Dr. Mpeta, your name was mentioned by Dr. Lwando.
Then I would disagree.
That you may have an alternative view. What's your take? Do you feel NEMA is contributing to healthcare financing as it should, or we are judging them too early?
Well, as it has been observed, definitely I hold a counter view, and this is based on my personal observations. And probably we can even talk about how we can rate. Now, we cannot really, just say that they have underperformed or they have performed well. I'll give an example. In the, collections from the formal sector in terms of contributions, they have done extremely well given the given period. That we give them a pat on the back. Now, if we look at expanding the best for contributions, probably I would not pass them on that. They still, are limping in that area. And looking at where we are, I expected that they should have given us a 5-year goal. It could be there, but the question is that has it been made available to all the stakeholders so that we appreciate where they are going with regards to contribution from the informal sector? That's number one. Number two, if we look at, application of the funds to where they are needed, I would say that it's half and half, and not really have performed very well. The reason why I hold this view is that, in my view, I feel like NEMA is misapplying the funds, instead of the critical areas where it's needed to where they feel it should be needed. So if sorry about that, our phone keeps on dropping. So if for me, I was to comment in terms of where they needed to have applied the funding, the huge funding that they have, collected, is to, build the health sector, or to be in tandem with the health sector the way it's built. The health sector, the primary base is primary health care. Then we go to, curative and rehabilitative services. So let me give an example, Dr. Mzezati. If you have Kotemukuyu tree, you won't start by climbing, from the leaves. You start from the the stem, and then going up to the branches and the leaves. Equally, I really expected NEMA to throw its weight, at expanding the primary health services, because this is where we have the bulk number of our citizens accessing care. Now, if we are able to actually provide these primary health services for free and ensuring that they actually meet all the adequate needs, then we start going, a ladder up and higher and higher. Now, NEMA started to, take the bull by its horns by climbing the tree from the leaves, and that, the leaves are not very easy to start from there. So you don't start funding these big surgeries that only probably, less of the population are able to access, and you forsake the primary services. For example, if I've got diabetes, can they check my random blood sugar from the clinic? No, they can't. Can I access my drugs under the scheme from a clinic? No, they can't. So these are some of the questions that NEMA needed to answer through their funding before we start, talking about brain surgery and cardiac and all that. Now, this is where, for me, I feel they have underperformed, because I expected them to really sweep the primary health care and ensure that it's solid in its, funding. Secondly, the other aspect I feel NEMA has failed is where, first of all, the constituent of the board itself failed the litmus test of following the law. All right. So if we have to start making corrections, we have to look at, are we following the law that we made for ourselves? And then we bring in, all stakeholders to ensure that we support NEMA both in the private and public sector. So I feel they have really underperformed when it comes to applying the funds where the majority of the people are, and focusing really on the curative services, where a number of tertiary hospitals are being rehabilitated to provide a service to a small number of people, as opposed to putting funding where a large number of people should access that, because that was the reason why it was, established.
So, Dr. Mzezati, I know we're running out of time.
Yes, we are running out of time. Let me get
so maybe if you can just allow me just
I'll get back to you. No, I'll get back to you. Let me get a reaction from Mr. Kanika. Mr. Kanika, there's this issue that Dr. Mpeta has raised, that some of the challenges NEMA has is that we didn't follow the law in the first place in establishing the board and other positions. What's your reaction to that? In less than a minute, I don't know if you can achieve that.
Yeah, okay, I hope so. I think I concur with what Dr. Mpeta said. And when I was a pharmaceutical president, I think for me, I wrote to the board chairperson for NEMA, by then should be Mr. Yamba, if I'm not mistaken, the former secretary to Treasury. And I wrote to question how they engage the director for NEMA. In short, I was just trying to show that they are supposed to be accountable to whatever the action. As you know very well, you cannot unpick a person like a director to go be a director here. No, you need to advertise. Once you advertise, you interview people and then you pick. But unfortunately, it didn't happen. But I wrote a complaint and I sent to the board chairperson by then, and up to now I've never received any feedback from that because I didn't see any advert. I think I also agree with what Dr. Mpeta said. Actually, NEMA was supposed to get on a tree, starting from down, then goes to the leaves. But they started going from the leaves, then they want again to try by all means to come back to start climbing the tree from the ground. One thing that we need to know is, in terms of contributing money, yes, they have received a lot of money, but what services are the people having access to these services? The answer is no. Are the drugs found in NEMA places or in hospitals where NEMA is offering? The answer is no. Are the people in rural parts of Zambia who don't have other private hospitals having access to the things that we are promised for NEMA? No, and we should know very well that the reason why NEMA was created is to cut out the out-of-pocket expenses. Now, are the people, are those out-of-pocket things be cut out? The answer is still a big no. Why? Because the systems NEMA is using, they are using the system that have proved to be very much in a moving in a wrong direction. Let me end here.
Amoyo, 1 minute. What's your reaction to this conversation before I go back to Dr. Lwando?
Yeah. So for me, I think the description that Dr. Mpeta gave is that health sector, it's a broad-based kind of pyramid. If you look at it in form of a pyramid, the bulk of the services that we provide are primary, and that's at the base. Therefore, we expect that for an intervention like NEMA, would first of all do apply it more to where the majority of the clients are going to be seen, which is at the base. And in so doing, I think that will help to boost not only the receipt in terms of the monies that they're able to collect, but in terms of benefits that are accruing to the majority of the clients. Provision of tertiary services is very, very expensive, and it can actually be catastrophic in terms of expenditure, even for the money that NEMA has collected. Imagine the treatment for just one open heart surgery. That would be a lot of money that would drain the resources. At the moment, we already have other streams of funding that are running side by side with NEMA. We have government that is still providing health services, so those resources can be concentrated there. While NEMA, we go broader by increasing beyond 30% of the people that are affiliated to NEMA. Maybe if we are able to reach a threshold of maybe 60 to 70% of the people being on NEMA, then the broad base is going to be covered by NEMA, and therefore it will relieve on the government budget that goes to providing free primary health care services, and these will be reimbursed by NEMA, so to speak.
Dr. Lwando, in less than a minute, what's your final thoughts on this?
Yes. Thank you very much, Dr. Mjarati. First of all, the guiding principles that NEMA was given in their first 5 years is to do away or not to involve themselves with one, infrastructure, two, human resource, the training of human resource, three, the primary healthcare. Probably that's where the mistake was made, because primary healthcare was supposed to be the foundation of the existence of NEMA. But we must realize that NEMA is not a service provider. NEMA is a purchaser, it's a payer. Just like any other insurance company, like Prudential, Madison, they don't determine what is being provided by the institution. It pays for the services that have been provided by the institution. As Mr. Kanika has alluded to, you go to a hospital, you have your NEMA card. The hospital doesn't have drugs. What is NEMA supposed to do? That's a very serious breach of the quality assurance. But then you might be interested to know that NEMA is under the same controlling officer, the PS, Minister of Health, as the service provider, who is, for example, UTH. So if I'm a NEMA card member, I hold a card, I go to UTH. UTH doesn't have drugs. I go to NEMA, I tell them this institution doesn't have drugs. What does NEMA do? How does NEMA punish UTH, which is under the same PS as itself? So this purchaser provider split that hasn't been in existence has created a very big problem on the existence of NEMA. And I would implore, because we don't have much time, the ZMA president, Dr. Crispin Moyo, probably you can organize a symposium in collaboration with Dr. Mjajati, so that we come together as a group and discuss this issue at length. You might also be interested to know that NEMA has been reviewing its benefits package. And I think they're even winding up in the next 2 weeks or so. But most of the stakeholders haven't been involved, and they're not even aware that this program is going on. And you see, that's where the lapse has really been. So instead of going back and just condemning what has been done, we all understand where the problems are. And we must appreciate that at least this thing started. From now on, now we pick it up. How do we split NEMA from the provider? We can't have NEMA operating under Ministry of Health, because then there won't be any quality assurance. That's one. Two, how do we ensure that NEMA pays for primary health services, which is supposed to be the backbone of health system strengthening of any healthcare provision? That's what we should be looking at. How do we ensure that the benefit package is widened and those services that are very costly on the scheme are removed, like heart surgery and those probably not really removed, but those who will crash the scheme. So how do we ensure that we attend to 1,000 patients instead of using resources X, instead of using these resources X only on one surgery? Because it's an insurance, it's supposed to benefit most people. If we can attend to 1,000 versus one person, I think that's a decision in health economics that we have to make. Anyway, in the interest of time, I think, gentlemen, we can organize a forum where we can
just
discuss
one last thing.
Now, Dr. Peter, I won't allow you. Here's what we're going to do, gentlemen.
I don't want to gag on.
No,
it's a suggestion.
No.
It's a suggestion.
No. We are running out of time.
It's a suggestion of the next topic.
Make your suggestion. Make your suggestion.
Okay. I think Dr. Rwando has brought out a very contentious issue of provider versus purchaser. Very, very important. And he's made very varied observations. But, he understands issues of health insurance, and I respect that. But he should notice that, as Kanika said, Mr. Kanika said, that NEMA seems to be running in different, direction, because the same NEMA has actually funded infrastructure in the hospitals. So why hasn't it funded primary health care as it was not, because it was not told? In fact, for me, I would rather fund primary health care than infrastructure. So what if you form a 5-star hotel in UTH and then label it NEMA, and my grandmother, who I am subsidizing health services, can't even get in that 5-star hotel? What's that? For me, I totally disagree. So I think let's start putting our money where our mouth is. Is it the money where, or the mouth where? I think let's start putting the money where value will be. And that's my conclusion. Thank you.
Dr. Peter, with that spirited submission, I think that the question of NEMA, we need to come back and discuss it in greater detail. And I'll tell you why we need to come back and discuss it in greater detail. Because the issue of NEMA, when it came in, and even when we were drafting the legislation, all of you here, we were all part of the team that wrote that piece of legislation. And as we see it unfold, from the time we drafted the legislation to where it is today, is it taking the direction that we want? It appears as a team, we are, one group is saying yes, the other group is saying no, others are saying, but also there's also a big issue that, Dr. Rwando brought out. It's the issue of governance and leadership, all right? If NEMA is headed by a board, why is it that you get people that are outside that governance structure interfering with what NEMA is doing? And so those are issues that we need to actually, discuss when we come back. But in closing this very spirited debate, I know that this subject is very big. Healthcare systems as a subject is a long subject and it's wide. But let's close on this very critical issue, gentlemen. And I'll give each one of you 2 minutes to talk about this, then we can close. In fact, 1 minute each. It's the issue, it's related to governance issues and leadership issues within the ministry. How has leadership and governance eroded public confidence in the ministry, and how do you fix it? I'll start with you, Dr. Moy.
Yeah, thank you very much, Dr. Mjajati. So for me, the health sector is, has, like others have already indicated, has been under a lot of stress, and most of the stress is arising out of leadership. Now, leadership, usually people want to think of minister level, want to think of PS level and directors level, but that's missing the point. I think the whole point is that we need to function within a system. Once a system is destroyed, once you destroy a system, it doesn't matter how good a minister you get or how good a PS you get. As long as the system is not functioning, you end up with a poor governance in any institution. So from the outset, I think we need to relook at the governance system within our health system, and we need to get back to having a properly defined structure. We need to be more structured in how we run the affairs of the different departments. I know the pharmacists will say that no, a few of us are employed more than maybe the nurses and more than the doctors, but that's neither here nor there. It's because a system is not a well-functioning, a well-oiled machine that knows that for us to move from point A to point B, these are the components that we need. It's like your car, Dr. Mjajati. If you want to move from one point to the other, you know that you need to service your vehicle, you need to have fuel, and you need to have all the different components. The same with the health system. If we want to have a functioning health system, we need to ensure that the system operates with fidelity, the system is transparent, and the system has integrity. And once those are all achieved, we expect that this is a system that is ready to deliver us from point A to point B in a manner that is consistent and that is predictable. At the moment, what we have, Dr. Mjajati, is that we have a system that most of the problems we're facing is because of knee-jerk responses or individual opinions superseding a system. Starting with HR, people are, the system increases from 7 directorates to 17 directorates within a blink of an eye. And within a blink of an eye, another minister comes, they reduce it to 7. And you talk about procurement. Things are procured that are not fit for human consumption, and yet they pass through a system that is supposed to be able to pick up anything that is not safe for human consumption. So we have a lot of systemic issues that we need to deal with. It calls for a lot of dialogue among all the stakeholders, and also the Zambians. Just to call on the Zambians, we need to advocate. We're doing it for our own good. It's not like you're doing anyone a favor if you keep quiet about issues. We need to advocate for quality services, because all of us are ultimately consumers of these same services. Today, I can drop dead here. I don't know what is being injected into my body. But I need to make sure while I'm still active, while I'm still able to communicate, that I advocate for quality products, commodities, and services in a system that is predictable in what it's able to do for me. So for me, I think we need to build a systematic approach or systemic approach where systems become king and individual preferences are either secondary or tertiary to what we implement in our programs.
Dr. Lwando, issues of governance and leadership as a contributor to low confidence in the health sector, and how do we address that?
Well, as the adage goes, the fish rose from the head. It all starts from the top. You know, we've had the situation where the HPCZ registrar CEO can't make a decision because he has to wait on someone higher. You've got Zamra waiting on somebody higher. You've got every institution that's operating under the minister, under the PS is waiting for them. So the issue of micromanagement has been a big cancer in the healthcare system. And that's one thing that we have to do away with. As the NMCA president has alluded to, systems have to function. Whether you are there, you are not there. Minister of Health receives 10 vehicles. Everybody is seated and waiting for one person to come and distribute them. And he will base his decision on the political ambitions. Let's send this vehicle to Mansa, for example, this one to Solwezi. And that's a very big indicator of systems that were rotting. So let's have, or non-existent at all, let's have systems in place. When you have systems in place, the head can be sick, the head can be sleeping in his bed, and the system will run smoothly. So systems, and systems. Thank you.
Mr. Kanyika, leadership. How has leadership and governance contributed to lowering the confidence in the health sector, and how do we fix that? Dr. Moyo and Dr. Lwando are talking about strengthening systems. They are basically saying that in the previous administration, systems collapsed. Everything was about one person and what one person wanted. And as a result, the system has collapsed, or rather the system is non-existent, and that's why we are where we are. So then how do we move forward? Mr. Kanyika, under 2 minutes.
I think I may tend to a little bit differ. I believe systems have been there for years and years, but it's the individuals that makes now the system to not to perform accordingly. So if we change the individuals, you find that the system are going to change. Let me give an example. We had issues of Andy, and what really happened, the permanent secretary for administration was fired. But again, we were expecting like she was the wrong person and the minister was removed. But what happened again? Days or months later, we heard about issues of fake vaccines and all that. So it's about the issue of individuals being there. Currently, the individuals who are there, apart from the minister, I think all of them, they don't have that support from the public, because the public consider those people to be like terrorists. And this is where those people need to change and have new people in the. I'm telling you the truth. I'm saying the truth. That's I'm telling you, that's the situation currently. When you talk about means of health, people think like they are like terrorists and all that. And the only person whom people think like they have at least bring a fresh air, it is the current minister. The remaining, people still don't have confidence in them. So you cannot talk about the system before you start dealing with the individuals. So for me, I may say, let's first start by cleaning out the individuals who are there. Then as we have new individuals, then we can say, how can we now tighten or strengthen this system that is already in existence? But how can the same people who make these things to go in a wrong way, do you expect them to bring a change? It's not possible. It's impossible. So in this situation, we have the same permanent secretaries, we have the same directors who were again involved in the issues of ANIB, who were involved in the issues of vaccines, who are involved in the issues of fake drugs. So how do you want the people now to gain confidence in the people where we have the same people who are there? It is very, very difficult. So what is needed first? Let the president clean up the entire, not only firing the permanent secretary for administration, why leaving the permanent secretary for technical services? Because the problem that we have currently are more technical than admin. So for me, I was thinking like the permanent secretary at technical service will first go, because that means it's more technical than administration. But the opposite happened, and I'm hoping and I'm praying that even the permanent secretary for technical services also goes, so that we have new fresh air. And after that, we also change directors who are supposed to be there. Some are doing nothing there. You see, we have directorates for a program. How can you have a directorate for program? Why should the program be a directorate at the Ministry of Health? So we have other department that needs to have directorates that are important to the running of the healthcare system. So for me, and I still believe, yes, I thank the president that he fired the permanent secretary for admin, but I'll thank the president more if he goes further to fire the permanent secretary, technical services, and the other directors who are there. They are part of the rotten system that have been killing the Zambian people. Thank you.
Dr. Mpeta, leadership and governance. How has leadership and governance affected or impacted the public confidence in the health sector? And how can we get it back together? Mr. Kanyika has just talked about flush the entire system. Dr. Moyo talked about let's strengthen systems. And Dr. Luando also agreed to say, if systems are strong, it doesn't matter which individuals are there, the system will still protect itself. Now, what's your reaction to this conversation with regards to leadership and governance in the health sector, and where we're coming from, how public confidence has collapsed, and how do we get it back?
Yeah, so thank you very much. First of all, leadership and governance is one of the pillars of a functioning, well-functioning health system. And I think a number of commentators have said that not only did we drop the bar, we actually lost the bar. So there was actually no bar to really compare to. And, where we are coming from, appointments could be made, in the corridors. Today you are directed this from the corridor, appointments were made on patronage. Appointments were made, on nepotism. Appointments were made on threats and political connections. You cannot have a system based on that. And then the issue of micromanaging, where appointments, including up to, a health post level, where coming from one office should be a thing of the past. What I believe in is each level should have a system of appointment, and at what level should this office intervene in that appointment, and then let these teams build their own teams. I doubt if, some of the director appointments were done by the PS. You find that some of the directors were just imposed on the PS, and he had to work with those and try to deliver. So you find that, the whole system were being appointed from one office. Like Mr. Kanika said, we had directors who have got no directorate. How can you be a director without a directorate? How can you have, when you have a meeting of directors, I know Dr. Moyo said of 17, at one meeting, I counted more than 30, people who were in a meeting that is meant for directors. So now you wonder, how many directors do we have? So it became very, very difficult. Some of, a broader, health issue were managed by 3-4 directors, all appointed because of certain affiliation, because of nepotism, and outright patronage. That should be a thing of the past. So for us to move forward, and I think, unfortunately, I may agree with the sentiments by the previous speakers, we need a system shakeup. The status quo cannot actually bring back the confidence that people have lost. So the first thing that needs to be done is a system shakeup, and system shakeup, it will mean changing a few players that will actually, see new faces coming that will bring about, the confidence in the system. Like we have said, we have had these systems for years, but, certain individuals, lost the bar so much that, instructions being given over the phone in the corridors were taken as, government instructions, which shouldn't be the case. We need to have proper systems. Like the president has said, all instructions coming from ministers to permanent secretaries who've been writing, and vice versa. We need to have all these which are traceable, not where somebody is asked who gave the order for the purchase. I don't know. I was called on the phone. I was what? That doesn't give confidence at all. So first of all, we need to shake up the system, and then we need to have people accountable and follow the laid down procedures in how to manage, a government institution. We have to remove nepotism, patronage in the appointments. We have today where you are competing, or you're not even competing. We know that, this is the most qualified person who is likely going to take up that position. the next thing you start seeing somebody who come from God knows, maybe Pluto or Jupiter, taking up that position. You know, today we have got a number of people, just even in governance of these hospitals, who are sitting at consultant position, who are probably not even, been to specialists or whatever we may call it. And I think it goes not just among doctors, it goes, to the nursing fraternity, the pharmacists and other paramedicals. It became the system or the order of the day where, appointments are coming from all over the show. And if you look at the competences of some of these, we find that they are kind of, uninspiring. And I'll talk about, the profession, Dr. Moyo, which you preside. And I think it's a big headache that you have, where now we have got common members of the public saying doctors cannot manage this. No, it's not that doctors are not competent to manage the healthcare system or sector. It's because of the appointments that we had, where we pick the incompetence over competent, We keep underachievers over the achievers. How do you expect the sector to move? So when we start checking up the system or the sector, we have to look at the issue of HR very seriously, because it actually brings back confidence and it also spurs thriving sector. So let's bring back the system of, people applying for a job. They apply for a job, they go interviews, and they are selected by a panel, not where somebody wakes up because they had a dream that, this person should be this, and then somebody is that. How do they perform? So I think, for me, this is how we are going to bring back normalcy, and this is how we are going to bring back confidence in the sector, where the people holding the governance offices in the sector are people who are deemed to be capable and who are competent and are achievers to actually provide the direction in the sector. I think this is my final word.
Gentlemen, we can go on and on. This subject is very long and exciting. I will take one final word from each one of you for 30 seconds. If you exceed 30 seconds, I'll cut you so that we close this segment. I'll start with you, Dr. Moyo. No, the president will finish at the end. I'll start with Dr. Wando. What is your final thought with regards to the entire subject issue? What are your final thoughts?
Yeah, my final thoughts are that...
How do we bring back confidence in the public sector in terms of service delivery for healthcare delivery? Go on.
Yes, a system flush out. Let's remove those that are perceived to be incompetent. Not only perceived, but were hired on patronage, as Dr. Mpeta said. Let's bring in competent people. Let's strengthen institutions. Let's bring to the fore governance and leadership. Let's do away with cadarism. Let's do away with patronage, and let's do away with policy directions that are not discussed. Policy directions that have no direction as per se. So in short, let's bring competence to the healthcare system. Let's bring in the right people, and everything will fall in place. Thank you.
Mr. Kanyika, 30 seconds. Your thoughts on the entire topic. How do we bring confidence back into the public service delivery system for health?
I think first thing first, we need first to flush out some of these people whom we know very well that they have been part and parcel of the confidence that the means of health have lost. Without doing that, then we are doing nothing. So what is needed? System system flush by changing individuals, and then we can try to strengthen the system with the new competent individuals that may be there. Thank you.
Dr. Moyo, as president of the Zambia Medical Association, and
here now
you ask you. Dr. Mpeta, sorry, Dr. Mpeta, because you gave a very spirited, So, Dr. Mpeta, your 30 seconds, sir. How do we bring back confidence in the public? Because public confidence is key, without which, to be honest, this sector, will not stand. So how do we bring it back in 30 seconds?
Thank you very much. First of all, it's very possible to build confidence by the public in the sector again. And this, as we have said, can only be done if we shake up the system and we go back to normalcy, where competent individuals, achievers individuals, are going to be placed in these governance positions, so that we start following the law, and so that we start having, policy directions that have got, targets and the directions to say. So it's very possible, and let's ensure that we put back, we put competent people in these offices, people who are resilient, who are not going to jump at any instruction just because it has been issued, but people are going to look at, is it lawful? Is it required? Should I do it? If I can't do it, then those people should be able to refuse certain instructions based on principle. Because a lot of people, forgot about their competences, forgot about their principles by just merely, following instructions that are not supposed to be.
Dr. Moyo, speaking as president of the Zambia Medical Association, you are now giving the position of the Zambia Medical Association on this question. How do we build confidence in the health sector in Zambia? How do we bring it back?
Yeah, thank you very much. So for me, I think I'll go just step by step. We need to ensure that we increase the coverage of our health services to cater for all the people, including those in our far-flung places in rural areas, by ensuring that we have well-resourced and well-financed health systems that are responsive to the needs of the people, wherever they are. Under recruitment, we need to ensure that we recruit adequate human resource in all health service delivery points. That includes all health care workers, including doctors, to ensure that our people are receiving the best that the country has to offer in terms of human resource. We need to strengthen the national health insurance. I know now it has moved from what I've seen from the documents circulating around. It's no longer sitting in MOH. It seems it to be sitting in Ministry of Labor and Social Security. We need to interrogate what was the rationale for that. Not that we're going to oppose everything, but to make sure that we understand the rationale. What is the thinking behind it sitting there? And where it is sitting, how does it benefit? First of all, those that are subscribed to NEMA, but second of all, how does it provide social security for our people who cannot afford health services? Thirdly, we need to ensure that our supply chain system, our drug supply chain system, is transparent, where we are able to follow where our commodities are consumed and ensure that they reach their intended beneficiaries, who are the end users. And in terms of supply chain, we also need to ensure that the regulators who are protecting the public by regulating what comes into the public sector are on the ball as far as standards are concerned. Then lastly, I want to also talk about the understanding of the governance. We need to make aware of our citizens their rights regards the services that they're supposed to receive. This will promote advocacy. This will promote awareness among our consumers of the services. Thereby, this will keep our leadership, whoever is providing these services, they'll be kept on their toes, knowing fully well that the citizenry is aware of what the expectation of the service they're supposed to receive is. And that, in a way, it will promote a healthy Zambia. As ZMA, we are going to be very interested in all matters of healthcare. We'll be involved, we'll be engaged, we'll come into meetings where people are used that ZMA should not be invited, as long as it's about healthcare, as long as it's about the health of our people, and as long as it's about public health, we are going to be interested. We'll ask the questions, we'll demand answers, and it's no longer just a wishy-washy approach that we're going to have here. And people have to be ready to provide answers, because they are presiding over public health of this nation. And they need to be accountable. This is the reason why they're in those offices. So we'll ask the questions and will be an advocate for the patient, both for their safety and for quality services. Thank you very much, Dr. Mjajari.
On that presidential note, gentlemen, I'd like to thank you for making it to this conversation. I think that this is a conversation we need to have again, because I think we left out quite a number of issues that we needed to touch. But of course, time was limited. I'd like to thank all of you for having come, and I'd like to thank the viewers that stayed with us all along. For healthy and prosperous citizens, I wish everyone a great more evening, and would like to thank our sponsors, MTN and IO. Gentlemen, do take care and good night.
IO is easy, and to sign up is just as easy. Meet Abel Mutula from the barbershop in Kalingalinga. Abel Mutula is also an IO customer.
My name is Abel Mutula. Signing up with IO was easy. This is how I signed up. Step 1, dial *296#. Step 2, select 1, sign up. Step 3, select either 1 for my hospital or 2 for my life. Step 4, fill in your age and confirm. Step 5, select 1 to accept the IO terms and conditions. Well done, you signed up. Now let's add my loved one.
IO together with MTN. IO, because you care.